Thank you, Sean, and welcome everybody. I'm Andy Cleek. I'm a psychologist by training, and I'm from the McSilver Institute for Poverty Policy and Research at NYU. And me and the rest of the team from NYU are really excited to be here today and be able to participate in this. Tara, can you move to the next slide, please? There we go. So I'm going to just take a little bit of time to welcome everybody, introduce everybody. We're going to go around. We have a little exercise for everybody to do just so we can all get to know each other a little bit. I think a couple things as we get started, as Sean mentioned, I think this is something we would usually do in person. We would probably all be gathered in a room eating bagels and sandwiches and whatnot. So we're going to try to keep this as interactive as possible today. And I encourage people to ask questions. You can, it's a small enough group, you can just ask your questions. I'll ask everybody to keep themselves on mute when they're not talking, just so we don't get everyone's kids and animals and all the other variety of background noise back there. But other than that, if you have questions, please feel free to jump in and ask questions. You can also use the chat to ask questions. But one of the things that I think is really important is that we make this as interactive today. And also the other thing to be mindful of, and I know Sean mentioned this as well, is this really is a pilot. And so this is kind of different than starting a new program in terms of we're really using this as a learning experience, and we want to learn as much of it as possible. And, the folks from Alliance and the folks from McSilver, we've all been locked. I want to say locked in a room, but we haven't actually been in a room in like a year. But we've been locked in this virtual room, putting this together for quite a while now. And so there may be things that we haven't thought about. So as we go through the training today or in the days and weeks ahead, and there's things that you, particularly for those of you who are going to be on the front lines doing this work, see or have questions about, please raise them, because sometimes there'll be something we've thought about and have a good answer about. And sometimes there'll be something we just didn't think about as we put this together. So to just be mindful of that piece and to raise those questions as they come up. We're going to walk through it today. We've got a couple built-in question times, but feel free to ask other questions as they come up. And we have built in a couple breaks today, because staring into Zoom for hours on end is tiring. And so we want to make sure people have a little chance to turn off their cameras and go and refresh and come back. So please, wait for those, and we'll do that as well. So we're going to go through a little bit of the philosophy about how we're approaching this training. We're going to go over the pilot in some depth, and this is where I think it really is important to just jump in and ask questions. We're going to walk through the tailored plan of the population, who's really going to be served by this pilot, how's all that going to work, how those people are going to be chosen, et cetera, the model of care management, eligibility and services, and Q&A. So over the course of this morning, we're going to get a lot of information out there. But again, please jump in and ask questions as we go forward, because I think it'll be really important. All right. So with that, I think I'm turning this back over to Boris. Thank you, everybody, for all your good food stuff. I think we all need to get back out of our houses and start doing new things and traveling again. So that was one of the themes. But with that, I'll turn it back over to Boris, and he'll start diving into the actual training.
Yeah, no, thank you, Andy, and everybody, and hopefully folks didn't get too hungry as they were hearing different foods. That was not the intent of this, but I appreciate it. And just wanted to, so Rosa just mentioned that she's learning. I just want to emphasize we're all going to be learning through this pilot, and working together. So we really see this as a collaborative and a partnership moving forward. So you'll probably keep hearing that over and over again, and we just want to keep emphasizing that this is not kind of a traditional, here's a program, go implement it. This is really making it, trying to make it work. And one of the things that we also talked about food and change and recognizing that during COVID, there's probably hasn't been a lot of new foods introduced, or even opportunities to do that. It also, to a certain degree, mimics of what this pilot is going to be, because it will be an ongoing change. And so again, just wanting to make sure folks kind of recognize, about this pilot. So as I think Andy and Sean mentioned, we get it to as far as we think we can get it to, and a lot of things still have to be worked out, and your ongoing feedback is going to be crucial to this pilot. Because what we want to do is kind of just jumping a year from now when the Taylor plans go live in 2022, we want to have the best information and the best system to put in place. So when they do go live, we have as much of a perfect model as possible, recognizing that there's always going to be tweaks, there's always going to be some changes, and especially when it gets to scale. But again, really moving this forward, and really appreciate everybody's work on this. So, and can't emphasize enough, please feel free to jump in. As Andy mentioned, you can unmute yourself and interrupt me. I am totally fine with this. I actually appreciate when people interrupt me. I grew up in New York City, so being interrupted is part of my nature. And so please don't hesitate to do that, ask questions. You can chat them in. And there's actually another option. I don't know if we mentioned, there's a raise your hand option if you want to do it that way. Please feel free to use any of those options to communicate with us, and slow us down if we're going too fast, or too slow even, and if we need to speed up a little bit. So just starting with our training approach, just wanted to review a little bit about how we're approaching. So there is a Kirkpatrick's 4-level training evaluation model that, working with Alliance, we're thinking is the best model to implement here, as kind of trying to get folks to, really the goal of any training is to get folks to a competency level. But we also recognize that to get competent in any area takes time, and you have to go through a number of steps. So the first one is really what we're doing today, right? It's really getting your reaction, starting to make sure that what we're putting together is, has a a good training experience, and that makes sense to you. When we get to level 2, we hope again that we're slowly starting to increase knowledge and the beginning of some proficiency, recognizing that in level 1 and 2, and this is basically how webinars work, this is basically like Zoom meetings like this work, is where you're really you're really at level 1, hovering at level 2, pushing level 2 at best, right? I don't think for myself, or I have met anybody who kind of left the webinar and said, besides saying this was a great webinar or a great training, said, now I know everything and I don't need anything else, especially if they're trying to acquire some new skill or knowledge. Usually it requires much more. When it gets more intense, it's really at level 3 and 4, right? As training progresses, where folks become a little bit more proficient, and starting to really see change in their behavior and how they're approaching their job. And they're starting to slowly apply the skills at a job, but not fully there yet. So they're already starting to use things that they have learned, and starting to implement. And really, level 4 is when individuals become fully competent, with focuses on learners' performance, and so forth. So those are kind of, as we go through different trainings, and we have a total of 4 different days of trainings. We changed the timing around a little bit, but you'll see kind of how we're approaching this. Just wanted to make sure you guys see that. So Terry, if we can go to the next slide. So as we continue with our approach, what we're looking to do again is in these trainings to really get you to level 1 and 2, provide the information, get to that kind of level. And what we're looking for Monarch to do internally, and we'll work closely again with Monarch, is to help especially the care managers is to start achieving level 3 and 4 in competency in hopefully the next year or so of this pilot. Again, understanding that it takes time. And in that scenario, what we're seeing, especially, I suspect, Lee will play a crucial role, but even others as well, is what we see is usually as information becomes available and we're doing some of the trainings, you start working internally with your supervisors and your senior staff in helping you really incorporate that knowledge, right? And that really happens on the ground. That happens case by case, scenario by scenario. It goes through potentially sometimes shadowing or coaching. in role playing. So there's many different ways to do this. There's no one um, kind of silver bullet here. I think it depends on the individuals, it depends on the organizational culture, and it depends on the approach here. But it's crucial to really take the information and start to kind of applying it and start using it and then working internally. So again, so if you think about, I like to use, kind of the medical, especially becoming a doctor piece, but even social workers or others, right? If you think about what happens in all of the healthcare professions for most part, right, when you get to a licensing level, there's really, if you think about these four levels, really level 1 and 2 is your classroom work. Is learning and kind of reading books and talking about it and being quote unquote trained. Level 3 and 4 are all of those internships, residency programs, and all of those programs where people actually practice and consistently get feedback on what they're doing. And any of the programs in healthcare that gets you licensing, again, from social worker to a surgeon, you have to go through all of these steps to really, at the end, to become proficient. And so we're really following the same protocol here in regards to getting, care managers up to speed. So looking forward to that. Unless you just want to take a step back. No, it's okay, Sarah, you can go to the next slide. Just want to take a step back, and I just want to make sure that folks from Monarch, especially Melissa and Lee, please feel free to also jump in. I think what would be helpful as we go through this training, and especially the future ones, maybe not so much here, because a lot of this is going to be overview. Um, Please feel free to jump in and also talk about how you guys are kind of seeing this, or maybe last week when you had your kind of onboarding, if you want to connect the dots and say, hey, and remember when we talked on Wednesday about X, Y, and Z, this is what I think Boris or Andy is talking about. Because I also want to make sure that this means something in the world of Monarch, right? So this is not just kind of this philosophical or theoretical approach, but trying to make sure that it connects. So please feel to jump in, not just with questions, of course, or comments, but also if you wanted to expand, making sure we connect the dots with Monarch. Or if anything we're saying that's not in line with some of the Monarch policies or procedures, we should talk about that as well. And want to make sure that we're not saying something that we put folks in an awkward position or situation here. So our training overview, we're looking to do 4 different trainings. So today we're really doing the pilot overview, care management model, and so forth. Um, on Wednesday, so the Tuesday, originally we had a training scheduled for Tuesday that's being rescheduled probably for maybe 2 weeks from Tuesday or so. Um, but on Wednesday, we're going to talk about components of health home care management, the foundations of care management, and community integration, and really spending a lot of time on things like services in the community, other elements of it. We're going to talk a little bit about telehealth, and so a lot of things that I hope are not new and probably Monarch covered, again, I suspect in some of the trainings you already had, but wanted to review and see, talk about it. So we'll have a full morning on that component. The 2 trainings on the bottom that's going to be done 2 weeks from Tuesday probably is the whole person and integrated health. And of course, we need to get you guys up and trained on the Jiva platform, which is basically the EHR or the health record, where you're going to be documenting your services. We're going to do some of the documentation training there as well, and talk about some of the measures and metrics. Um, One of the things, just coming back to the whole person and integrated health, is to emphasize, and we'll talk more about this. Is this program, again, I think it's different probably from some of your experience, is, I know we talk about integrated health and behavioral health a lot, and there's a lot of integrated programs out there. And again, I suspect you have some experience or a lot of experience in this. But this, the goal here when Taylor plans go live, this is really for Alliance Health going to be also a change, because it's no longer just going to focus on behavioral health. It's going to focus on a whole person. It's going to cover all elements of physical health and behavioral health and social determinants of health. So when we talk about whole person and integrated health, we really mean that as a care manager, that's your responsibility in many different ways. And so we'll talk more about what that means, and we'll spend a lot of time on it, wanting to make sure that that's part of what you guys are doing. So more to come on that. In addition to the 4 trainings that I just discussed, again, kind of trying to move you guys from level 2 to level 3 slowly, is we're also going to offer after those trainings a recorded health literacy webinar. So these are pre-recorded. You can do it at your time. Kind of they're half hour each, so they're not very long. You'll do it at your convenience. You'll have access to these kind of webinars, if you will. And again, emphasizing that physical health part. So one is going to be just health literacy, primary care. Another one is going to be really the role of care management in diabetes. Same thing, the role of care management in cardiovascular disease, and of course covering some of the other big kind of areas of disease management like cancer, chronic pain, physical impacts of alcohol and marijuana use, and so forth. So again, those are going to be just webinars that you're going to be able to log in and listen at your own time. And after those are finished, what we're also hoping to do, maybe 2 to 3 months after you get some of the experience in the pilot, and some of the, kind of maybe additional questions, is to provide what we're calling booster trainings. This is just our initial thinking. There might be more booster trainings. We're also going to look to you guys to tell us where other things you might want to kind of talk about. But those, again, coming back together about whole person, foundation of care management, and probably additional Jiva trainings. Lee, I'm not sure if you wanted to jump in. I see you're unmuted, but
Yeah, so I just had a question about as far as training goes. One of the things with our education department that we had been talking about is there is a lot of overlap in the trainings that Monarch had assigned um, within our Relia system and some of the information that we're probably going to cover here. And so I wanted to see if for each module or for each training, if we would be able to get a certificate of completion so that I'm trying to think like in the future as we go through this, it may be that we don't have to do some of the Relias trainings internally with Monarch because the training that we're getting through this would suffice.
yeah, no, I think that's a great question. I think, I'm not sure if Alliance folks have any initial thoughts on it, but I definitely think we should think about that. I don't see why we wouldn't be able to provide a certificate of completion.
Yeah, I
Anybody?
don't see why we couldn't figure that out. So let's follow up on that, Lee. But I think that's a good idea. There's no reason we can't work up something out with that.
Yeah, and not to confuse folks further, but I think that even probably bleeds into, especially for an organization like Monarch that's not just in the Alliance region, right? Where in the future under Taylor Plan, you, I suspect, might be doing care management for a number of different Taylor plans who probably will all have similar, because it's a state-driven requirements, a lot of it, not all of it, but a lot of it are. And I suspect there'll be similar training requirements by other Taylor plans. And I know the state, I think, is trying to establish something, or at least, or encouraging. Maybe they're not establishing anything, but because I don't know if this, they're doing that, but at least encouraging, I think, Taylor plans to, so this way, I think hopefully it could count if you're doing similar work in somebody else's region.
Absolutely. And that's part of what stemmed that question is I was reading through the provider manual and I know that there's some tweaks and updates and stuff going on, but I was reading through the provider manual and it was saying that, if you are doing care management in multiple coverage areas, then you would complete your training with the one where you're seeing the largest number of the population. And then it would count towards those other areas. So that's where that certificate of completion would come into play for sure.
Yep. Allison, I'm not sure if you wanted to jump in or you're just unmuted. Just that's the problem with Zoom. when you see people get unmuted, you can call them out.
No, I just agree with what you're saying. I don't know if we're at a point where we fully understand what they'll require. So, but I think that we will get there.
Yeah, definitely. And what I would say, not today's training, except for maybe the last part when Alliance does their overview of kind of their systems towards the end of this training. But the first, I would say 3/4, 2/3 of this training today is clearly just about the pilot, the overview, just to make sure everybody's on the same page. So that's not something that, of course, will exist when we tailored plan go live, right? Today's training, except for the last portion. But when we get to care management and the whole person training, the care management on Wednesday and the whole person training, a lot of the areas we covered there come directly from the kind of the state requirements. So we're already kind of, even though we're at least over a year out, we're already thinking about how do we make sure at least the topics and areas get covered from what the state is, because they did have an extensive list of training areas. So hopefully as you see the Wednesday's training, you might recognize some of those areas that were in many different state documents. But thank you for that. That's a really good question. All right, next slide. All right, so let's just do some of the pilot overview. All right. So again, I think Angie and Sean kind of covered this, but the care management pilot was developed with Alliance, and now that we're working closely with Monarch, we have those regular meetings to incorporate your feedback. And again, we're trying to simulate as close as possible what this potentially would look like next year when tailored plans go live. We only have you guys, one care management team, as we call it, and one agency to work with. And again, really excited to work with you. And it's going to go, at this point, it's slotted to go through June 30th of 2022. And the only reason it's June 30th, 2022 is because unless something happened over the weekend, the tailored plans, I believe, are slotted to go live July 1st. Of 2022. So that's kind of the thinking about here. But again, this could, of course, change, one, depending on the feedback, depending on what the state does. It's still, really, on one hand, it's not really that far away, but at the same time, it is. So more updates potentially could happen. But that's the current thinking, at least, as we think about the pilot. Right, next slide. So our goals is to provide, again, better understanding of the care management model, the impact of the model, right? So we're also going to be closely monitoring how the individuals you work with, the Alliance members are doing. So what is it impacting and how is it impacting Monarch as an agency and you as a staff? To better understand the training, we want to make sure the trainings are helpful. What are we missing? What are we doing that we probably shouldn't be doing? We're also, as this progresses, going to start thinking about how much of this needs to be done. I'm going to say live, because in 2022 we'll be doing things live versus Zoom, because I think we'll continue doing things over Zoom. Or could it just be, like Relias or some other modules that people can just take at their time? So we want to understand that too. We're also testing, even though the way Monarch gets paid, is different, but in a background, kind of a shadowing process, we're going to be testing the reimbursement model. Again, not impacting your arrangements, but that's one of the goals. And overall, to better understand the functionality and the needed for successful care management, right? What are those IT needs, the documentation needs, the QI compliance, reporting and data, like any other program, what really fits into this, and we'll be monitoring all of that and working with you closely on those areas. All right, next slide. All right, so as I mentioned, let's talk a little bit about the population overview and acuity, and talk a little bit about what even acuity means. So next slide. All right, so this comes directly from the state. This wasn't something, the next couple of slides, something that we put together, but just to give folks an understanding what the state is seeing as the population that's going to be served in the tailored plan. So this is tailored plan, and then of course Alliance, did their analysis to pick the members that you're going to be working for this pilot that will be part of this. So again, the individuals with serious emotional disturbance or SAD or diagnosis of severe substance use disorder or traumatic brain injury. So just one of the things to mention here is this pilot will focus only on behavioral health, which will include SCD and SUD population. We are not targeting trauma brain injury population. However, even though that's not targeted for this pilot, it doesn't mean that necessarily you might not encounter some of the individuals who actually have TBI. Maybe they haven't been diagnosed with it or have been diagnosed but not known to Alliance Health. So that's something we're going to need to work through this pilot. But of course, as the Taylor plans go live next year, that will be part of the population. So again, when it comes to traumatic brain injury, that's not the goal of this pilot, but I wouldn't be surprised if there might be a member or two that you come across that actually falls into that category. And then the individuals with mental illness diagnosis who also meet any of the following criteria, right? So that includes, again, individuals with serious mental illness or serious and persistent mental illness, individuals with 2 or more psychiatric hospitalization or readmission within the prior 18 months, individuals who had 2 or more visits to the emergency department for psychiatric problems, again, in the 18 months, and are assessed by the department as eligible for Taylor Plan, an individual known to the department or LME, MCO to have had 1 or more involuntary treatment episodes within prior 18 months. And if I'm not mistaken, Allison, Kate, and others, the state is determining these, in the beginning of that. So the Alliance really just gets kind of a list or information. Is that correct?
You are correct.
All right, thank you. Okay, so actually, thank you for the question. So we got a question about who's collecting this data. Really a good question when this comes. So our understanding is the state is currently collecting this data. This data for at least the eligible population is being predominantly collected through claims, meaning as hospitals bill for hospitalization or emergency room, or providers, bill for, different services. So that is goes to the state in many different ways, and they're kind of analyzing and looking at that data. To kind of determine the population. One of the things just to mention, I think, one of the nothing, probably that will surprise you, but and the state is aware of this as well. Unfortunately, some of this data is, old, right? Because by time somebody bills and the state recognizes that there were actually 2 visits, could be actually a year from now, or 6 months or 3 months, and then it has to go through an analysis process. So some of it is not ideal because of the timing issues, but it is something that the state collects. And of course, Alliance has a lot of this data too. So I don't know, Allison, you wanted to jump in here too?
So there is some ongoing conversation between MCOs and the state as they set this out and refine it and look at their data together. IT is doing some of that. But the other thing you should know, not so much as being care managers in a pilot, because your members will already have been assigned, but for Monarch as an organization, I can't exactly quote it, but you can both opt out of being in a tailored plan. Although if you choose to do that, that eliminates you from the services that only the tailored plan provides. And you can also, there is a form to request getting into a tailored plan in which you would have to show that you had met criteria. And I don't remember all the details about it, but there is a backstop for, for those delays or when mistakes are made or things like that. The other thing is that people are not dropped automatically either. There's a time period where people remain in a tailored plan after, like you get somebody becomes stable and they're doing well, and now they could step down to standard plans, and there's a time period where they look at that so people aren't constantly being jerked back and forth between the two plans. And the last thing I'll say about how this works is that Monarch, as they are making their applications to become a care management agency, will decide what populations they want to serve. So ultimately, when Monarch gets up and going, they may decide that they want to serve individuals, be a CMA with populations serving IDD or serving adults with mental illness or children with mental illness. And so it will be the agency's decision what kinds of populations they will ask to be certified for. And that's based on what populations Monarch is serving already, not just in our region, but across the state.
Excellent. Thank you. That was very helpful. Yes. So yeah, I think the population and a couple of other things that reminds me, Allison, when I did not mention. So I talked a little bit about TBI, but for this pilot, we are only focused on adult population. So, you know, when the Taylor plan goes live, clearly children will be part of the Taylor plan, but not for this pilot. There's a whole other discussion about foster care and so forth, but that's for not for this pilot. So I just wanted to mention. And the other thing that we did not mention, I know we talked about recording and potentially making the recording available. We're also going to make sure that the slides, at least at a minimum, are available for you guys, you know, as well. So just wanted to kind of take a step back for a second. So continuing in some of the criteria here or eligibility for the population. And again, individual who, regardless of the diagnosis, meets one of the following criteria will also be included. Individuals who had at least 2 more episodes using crisis services. It seems, you know, 18 months seems to be this magical timeline within this. So again, so this is emergency room, you know, hospitalization, even crisis services will trigger the potential for the Taylor plan eligibility. Individual receiving any of the following acronyms listed here, BH, IDD, or TBI, you know, and of course, services that are covered by LME or MCOs, and who are individuals who are receiving or need to be receiving all of these services as well through some of the funds by state, local, or federal, or other non-Medicaid funds. So again, it's a pretty wide net in regards to eligibility. And to Allison's point about folks kind of when they get into a Taylor plan, you know, being there. I know in New York and some of the other states, what we've seen, just as people become eligible, some of the states have created what they call it a lock-in period. Each state kind of does it their own. So we'll see where North Carolina does. Usually it's at least 9 months or 12 months. And what that means is after you opt in and you say, yep, I want Taylor plan, this makes sense for me. And I, you know, and you get assigned to it or registered in the Taylor plan as a member, you basically stay there for 9 months. That would be potential one. But again, we got to see what North Carolina ends up with it. But one of the things, as Allison mentioned, which is important with eligibility, as we know, eligibility changes sometimes, circumstances changes, and everybody recognizing that if somebody keeps jumping between different plans, between standard plan and Taylor plan, and care manager agencies and so forth, that's not really the best way to coordinate care or work together with individuals to really help them in their route, you know, their recovery journey. So, you know, that's one of the things. But again, more information to kind of to obtain from the state on this. So if we can go to the next slide. So part of it, as we talk about eligibility, you know, so somebody's eligible, but it doesn't mean that the individual needs are all the same. So the state, as a lot of places talk about acuity level, and really acuity level is a way to stratify risk or stratify, you know, the need that the individual needs. And this way, hopefully it helps you as a care manager and care management agency to better understand the member needs, right? And so usually the algorithm is determined, and I think, you know, North Carolina is looking to do this, is in a high medium, and low risk. So the individuals will fall into one of those three categories. Here, there is a potential movement, within a certain time frame. I don't think it's going to probably happen, um, every day. But again, there is those three categories, and we'll go through each one and what they means. And again, the factors and the data, back to the data question, that determines this kind of risk levels. Our claims data will be always part of any kind of analysis and decision making. And again, it's cost, but other pertinent information might be too. So maybe somebody is not going to the emergency room or the hospital, but they getting 3 or more services every week for the last 30 weeks could be a potential other clue, right? So it's a very intensive maybe service array. So again, some of the factors that might impact what acuity level, how much is the individual connected to care, which is hard to tell sometimes, meaning are they not really connected to anybody? Maybe they're only showing up once in a while, you know, and maybe that's okay because maybe they don't need more. But again, do they have connectivity if anything does happen? Who do they call to get that care? Potential clinical data that's obtained from assessments, right, care plans and so forth that you guys gonna do could in the future help out or provide us in the community. And of course, as we know, social determinants of health could be a huge impact and factor to developing what acuity level the individual is going to fall into. So those are just some factors that are part of it, but recognizing that we will talk about acuity levels and recognizing that, of course, the higher the acuity level, the more the individual has needs. So let's just go through those acuity levels. So let's start with high. So one of the ways we're thinking, and again, this is something we hope to learn more about with you guys, is but right now we're looking at somebody who has no connection to care or very limited, right? Maybe they're seeing their primary care physician once every 2 to 3 years. They're, having any connection to even behavioral health services. Maybe they're just going, to the emergency room as a means to try to, get their medication or other things. The other piece is since the member has limited or no connection to care, we see you guys as serving kind of as a central point of contact, at least initially. So, that leads to a more of an intensive work with those types of individual. On an average, we probably see this being a weekly contact. We're going to use a lot of in-person here, but clearly this is where you're going to work with Monarch, right? On their policies and procedures, being in the pandemic, what does it mean to work in person versus Zoom versus phone call versus whatever other means you guys have. But so we're kind of writing this almost, as post-pandemic or actually what would be preferred. And we know for people who are high acuity, in person would definitely be always preferred. And the goal is to really engage the member in care management and with treatment services because they're so disconnected with treatment. And of course, provide social determinants of health support. So that's kind of the high acuity member, kind of a quick overview on that piece. So next slide. When we get to medium acuity, we see this individual as limited connection. So, maybe they're seeing their doctor, maybe they're seeing their behavioral health specialist, sometimes, but it's really inconsistent. They're kind of in and out of care a little bit, but at least they have some connection. And there is others in the community that are working with them, even if it's on a kind of intermediate kind of basis. And so again, so since this individual has limited connections to care, this is where your job becomes you're kind of starting to fill those gaps, right? The gaps where the individual is not in touch with the care providers and any of those additional supports. Maybe instead of weekly, you can do now more like maybe twice a month or so. Some connections, and again, still prefer those in-person touches, making sure everything is okay, making sure that we strengthen those connections to care, and if necessary, depending on the situation, because it's medium acuity, maybe some of the social determinants of needs are met. Maybe some are still need to be developed, but definitely want to make sure we don't miss that. And then when we get to the low acuity, the next slide, please. This is where we see really the member is connected to care, hopefully, going to their appointments on somewhat of a regular basis. And, since the member is connected and we're saying, we hope that people who are connected to care, their hospitalization, their emergency room, their crisis services are not as utilized as much because they're utilizing their services with their providers on an outpatient basis. So when they're connected, we really see you as providing that ongoing support and engagement is needed, right? Here, we definitely see moving from in-person, maybe to telephonic or Zoom or whatever other means you can do. In person, of course, when necessary, coming out and seeing the person from time to time. You're providing some additional maybe supports to treatment team, right? So you're working, ideal situation, you're working closely with other providers, trying to figure out what other additional supports might be helpful that are missing. The goal is to, again, maintain the member engagement. So if you're kind of seeing that they're becoming disengaged or something is going on that might break that connection and that stability, the goal is to really then intervene in that area as soon as possible. And then, of course, even though somebody might be low acuity and has connection to care, we shouldn't assume that social determinants of health needs are all met. Clearly, people might be still struggling with some of those, and so if necessary, continuing to provide those social determinants of health support. All right. So I think we wanted to pause here and see if there's any questions or thoughts or what you guys think about our thoughts, especially around the acuity and any additional any initial reaction. Because I know it was a lot of information.
I was just kind of thinking through what it would look like as we're working with someone, say initially they're identified as low acuity. And our care management team is working with them and they realize, this person's actually more medium or high. What that is going to look like for us to adjust that acuity level. Is there a process that we're going to need to go through to make sure that, other than our own internal, documentation of the reasons why we feel this way?
Allison?
I don't think that's been set yet. There has been discussion about, bringing back and providers, having that be a dialogue, but I don't think that the state has set that clearly. And I expect that is something that ultimately, well, it may not have to happen statewide. The challenge is that the per member payments are based on the acuity that you start with and how long, and how fast do you move those up. And then we have to justify to the state. So I think the answer will be yes, but how that will look and how we will do it, I don't exactly know. I will say this. I think that for somebody's acuity to be going up, I suspect, unless it is totally a social determinants of health, you actually should see it in claims, although there would be a lag. You would see an increase in visits, or you would see a new diagnosis, or you would see
Right.
a increase in crises. And it could be that what ends up happening is that for a period of time, you see them more than your PMPM. You do that increased visits. It comes out in the wash because you're serving a large number of people, and some are moving up and some are moving down. But it is challenging to figure out exactly how that's going to work.
Yeah, and I think that the delay in the claims that would support it from that aspect is where it is going to be kind of that learning curve.
Yep.
For us on the ground doing this, because we will see it in real time.
Well, one of the things Boris has pointed out is that this is in fact an advantage of doing the pilot, right? Because as we get experience for how that looks, and how much that seems to be happening and all of that, that's an opportunity to talk to the state about how to do this, or to figure out within Alliance, well, what's it going to take? And, you know, because the flip side is you can't just have everybody saying, oh, everybody's much more acute, you know, acute than you think. So there's that balance. And I have seen mention of exactly what you're referring to, but not a clear discussion at this point about how that would occur.
And I can imagine it would go the opposite way, that people may move, you know, would move down in acuity as well, because
Absolutely.
their claims data from a year ago may have put them at high or medium, and, you know, now they're more stable because they've been participating in treatment.
That's right.
Yeah. Yeah. And we've seen that, Andy and I have seen that in a number of projects we've done in both, where because of the claims data being the predominant data that drives this decision, Lee, exactly what you said, you know, last year, let's use last year, because that's, I think, a perfect example, right? I think everybody's struggling, everybody trying to figure out, you know, people losing their jobs, you know, a whole bunch of things are happening. It wouldn't be unusual that, you know, for some folks, last year's data might be showing really, you know, a lot of high level care potentially, right? And then by the time you guys getting out, and I'm going to be really optimistic about it, things are getting a little better. You know, summer is basically, you know, around the corner. People are feeling, you know, all these things. So when you get to them, even though they're high acuity on your list, because last year they had hospitalization, the emergency room, and all that stuff, this year they're like, I don't know what you're talking about. I'm doing great, right? I'm going to see my doctor. I'm going to see my therapist tomorrow. Like, you know, why do you, I don't need you to come here every week. I'm okay, right? You should have been here last year, right? You know, and so, and that could be the reverse, right? And so, yeah, definitely. But with this, you know, one of the other things that we need to think about, and I think the states struggle with this, to try to do this, is what is the instrument on the ground that determines this, right? Because, you know, how much is it subjective versus objective? You know, like, you know, is it just like, you know, as Allison pointed out, you kind of walk in and you're like, oh, this is really a high acuity person, and then the question is like, why? What is telling you that this should be high acuity or low acuity for that matter? Because you also don't want to you know, you know, kind of report on that, because if you're thinking they're low and you're not really touching them, but they're really high, you're missing all those opportunities. So what are those instruments and tools and methods to on the ground that's outside of the claims data that will allow you, right? Is there such a thing as a PHQ-9 for acuity level, right? Where you kind of ask 4 questions and it magically tells you what acuity level that person should be today. I don't think those tools exist today, but we need to think through, and that's one of the things, as Allison points out, in the pilot, we want to know how does that get assessed, at which intervals that get assessed, and what are the triggers that happens with on the ground.
Yeah, I would just add to that too. Go ahead.
Yep.
No, go ahead, Andy.
I was just going to add to that too, that part of the pilot is also figuring out the contact piece too. Because, you know, we've taken broad generalities of, you know, once a week, once a month, phone, not phone, whatever. But part of the pilot is also teasing that out. You know, are there groups of people who really need more than we've suggested? And are there groups of people who need less than we've suggested? And I think, you know, some of that, I know Boris and I have seen this in other places, that some of that goes both ways. But all of this at this point is on paper. And so this is where it's going to be really important to hear from the Monarch folks, you know, especially the folks who are on the ground out there doing the work too. Like, you know, what are you really seeing? Because the goal is, you know, to make sure that very few people are in crisis and they're getting what they need. And also, and, you know, I know when Boris and I started this process a long time ago, part of it was because New York had a very robust care management program to begin with. And, you know, part of it was there was a group of people who are getting, you know, weekly visits who just didn't need weekly visits anymore, right? They were kind of saying, well, I don't need you to come to my house anymore. So when we start there, you know, so when we start this process, kind of what do you guys see on the ground? And then how can we adjust that? And I think that's important to know for the Alliance before they roll this out at scale as well.
Allison, were you gonna say something to just?
I think there's, you know, it's going to be interesting, I think, in terms of talking back to the state, because ultimately the state sets the acuity levels. And certainly at least to start with. And you need to remember that that's a population health approach, meaning out of all of these folks, all of whom are essentially have high needs, because that's what gets you into a tailored plan, which is the highest, medium, and lowest of high. You know, so that's one thing to keep in mind. And you're serving people as individuals, but acuity is set as a population. And so, you know, kind of like, where are you in the groups in that population? And I think we'll sort of learn what, and frequently when I try and look at in different populations, you know, sort of what's the highest risk, it's what factors, and we don't always know what factors. You know, it might be something like homelessness, or it might, you know, I mean, I think that's part of what we're going to get. What is really increasing somebody's risk? And then the second part of this is that when somebody's in an acuity level, and this speaks to Lee talking about, you know, how fast can you speak back to somebody needs more or somebody needs less, particularly if somebody needs less and wants less, because you are, in order to be paid, you're required to do a certain number of visits or contacts. They aren't all visits. And so if somebody's at high, but you really think they should be low, in order to get paid, you still got to do those 4. And so that's sort of a challenge. And so it speaks to the importance of being able to speak back and forth, not just for the organization, but so that you can do what the member wants and needs. And I think that's, you know, because you could do more visits and still get paid. That becomes a problem for Monarch, because there's this work that you're not getting. Well, you're getting a payment, but maybe the work balances off. But also when somebody really is going, I really don't need you here, and they really don't, then what?
You know, I just think, yeah, I think agreeing with everyone says, I think this is going to be something that's really going to be important for us to figure out the best way to track, like how often. Again, we're not going to be starting with the state's leveling. We're going to probably, I think Allison probably provided a risk score, kind of the way we developed it. But, you know, what I have learned from talking to this, some of the AMHs who are going to be doing AMH3 for the standard plan, is that the state has been willing to talk about some things. They've moved back on some of the measurement requirements. They've made some changes on reporting requirements. I think the state is why they have their vision. I think if we're collecting good information, it sounds like they're going to be open to hearing about it. You know, and you know, we did talk about this as part of our readiness and RFA response, and so we'll continue to share that with the state. And at some point, it'd be probably even great to invite the state to 1 or 2 of our kind of, you know, as we're going meetings after they got the silent period, just so they can hear this kind of the kind of the real world, you know, the real world implementation and how it's going. Because I think that's a good point. You know, I would expect that, you know, I'm hoping that very soon you get a bunch of high-risk folks who are getting support they need. Hopefully they kind of go in one direction, but I also worry that the state's going to have a hard time setting accurate risk scores for a bunch of folks who are really totally disconnected, who probably need lots of time. And you hope, to Allison's point, at the population, even though you're getting paid high for Johnny, low for Susie, that between the 2 of them, it kind of averages out. But I think, you know, we're just not going to know till we do this. But I want to figure out to make sure we have a good way of recording this. You know, maybe it's just the contact recording that we'll be able to go back and show. But I think it's a great point, a great question.
Yeah, definitely. And again, you know, there is a difference between the pilot and what's going to happen right when the tailored plan goes live. So right now, you know, for the pilot, you're not getting paid to make those 4 for the high and so forth. But as Sean said, we still want to track this. And one of the things we want to do is more rely on you on on the decision making on what the person needs rather than their acuity, right? So we went through the acuity and we went through kind of what we think and what the state thinks. But one of the things of the pilot, we want to make sure that you don't just follow that and say, well, in a pilot it says high, you have to do 4. We really want your feedback on how'd you decide that it's 4? Did you do 4? Maybe it's 6, maybe it's 8, maybe it's 3, maybe it's 2. how do those decisions made? And so because the pilot does not tie you to the payment, I think this is a great opportunity to really give you that freedom to make those choices and provide that information back to us. Because at the end of the day, if the pilot, if you guys are still following what these 3 slides talked about, then we might not get enough information, because then we'll end up with high did get 4, low did get 2, and and so forth, and it's not really what we're looking for, right? So the flexibility for you guys is great.
And I think as we're going through it, as care managers and our peer support specialists are interacting with the individuals, we're going to see from the individuals what they need in real time in that moment. And so we may have an individual who for a couple of weeks needs some really intensive supports because they're going through whatever this is. And then they don't need that intensity for 6 months until the next crisis or situation happens.
Yeah, exactly. Yeah.
I do think though that when you rethink acuity, that some of what you're talking about, that really short term, that will be sort of part of the role and part of the population, because you can't redo acuity scores every week.
Right.
Yeah.
On
so
the
I think
other, if somebody needs something over a longer period of time, in what way do you change that?
Yeah, but
Or
part
less.
of our part of our analysis is going to be looking at that data, right? So looking at like, this month you did 8 visits because somebody was transitioning or doing something, and the next 6 months you did like 1. How often does that happen? Does that happen? How would that, if we were paying you, kind of per member per month, or like that monthly payment, how would that impact? Like all of that is going to go into the bucket of analysis and see. But yes, acuity can change weekly. It probably wouldn't even change monthly. We haven't really seen it where it jumps from month to month. It's more like quarterly usually. Acuity's change, it has its own things. But again, I think we want to test all of that. But what we want to make sure is exactly what you're talking about, Leah, is in this pilot that you provide during those 2 weeks what's needed, and then provide what's needed those 6 months, because it might be extremely much less than those 2 weeks. And that's fine. And that's exactly what would be great, because we can do then the analysis on also talking about that.
So
Yep,
and Lee, oh,
go ahead, Anna.
sorry, I was just going to say, in our weekly Monday case consultations with Dr. Reed, that might be a great opportunity, and I'm sure that's probably already going to be a part of it, to kind of talk about, risk factors, protective factors, what's going on with the individual that we're serving, to try to determine where they're at on that scale, and maybe over time develop some sort of quarterly reevaluation checklist, or use that as an opportunity to kind of discuss where they're at and where we need to be and what we can do to get there.
Absolutely. I think as long as we're meeting each individual where they're at with their needs in that moment, then we're doing right by that person, and that may paint a different picture at the state level for how they classify people, and how they say 4 contacts a month for high. It may end up, like Boris was saying, it may end up being more, it may end up being less. But I think if we're engaging with people and working with people with what their needs are in that moment, and using that consultation with Dr. Reed for that integrated health perspective, we're going to do just fine.
Yep.
One of the things I wanted to throw out was, just like there's a tail on people moving from tailored plan down to standard plan, being stable, and that tail is fairly long. I think a lot of times in behavioral health, we think about the most recent crisis, and we think in very specific terms about like getting them to the next appointment, which is really important. But one of the things about integrated care is both all of the care elements, but also we've been seeing a lot about from our TCLI program, Transition to Community Living, about people losing housing much, much later, about not having functional skills, about social determinants of health, in the physical health, about learning to manage your illness. And so I think another piece of learning is not just sort of handling that immediate crisis, but really getting somebody to a point where they can adequately manage their own life and in more dimensions than we've thought about. And so, when you think about those further visits, it may not be about crisis management. It may be about helping get somebody into a recovery program, or understanding and linking to all the aspects they need for their physical health, or figuring out whether they actually have the functional skills for the apartment they got. And so I just want to throw that out there, although I agree with everything everybody said.
Yeah, no, that's great. No, I totally agree. So just want to be, and thank you for the questions and the conversation. Really appreciate this, and this is exactly what we were hoping to get. So looking really more towards this. So I think what we're going to do, if I'm not mistaken, the next slide we should say 10-minute break. So it's 10:55, or at least that's what it is in New York. I assume it's the same in North Carolina. And so let's regroup at 11:05 so we can do bathroom breaks, maybe refill water, coffee, whatever it might be, and we'll start in 10 minutes or so. So let's just jump in. And so the next section is, we really wanted to talk about the model, right? Kind of our vision and what we see this model looking like, and really kind of having the discussion around the model, meaning the care management model, right? So there's the pilot, and there's really the structure that we kind of asked Monarch to look into and put together related to it. So as you know, right, there's, as we talked about, each team, and a team, it consists of 3 people, manages all 3 acuity levels. So one of the things we're really looking to do here, and one of the experiences we have in care management, and not necessarily it's bad, but what we're trying to do, exactly like the discussion we had, that people move in acuity, right? Circumstances change, situations change. People go from high acuity to low to medium and backwards. We just had that discussion. So recognizing that it happens in kind of an traditional, and I would say old-fashioned care management, what we've seen is usually you have kind of care managers that focus on high acuity, some will focus on low and medium. And then what happens in, kind of a lot of times is people actually get transferred from one care manager to another because of their specialty or their ability to serve that acuity level or work with that population. And what we really is trying to do is put a team together that manages all 3 acuity levels. So as individuals move from acuity to acuity, they really don't lose their relationship and contact with their care team. And that's kind of the main goal here in regards to putting a team together, rather than assigning X number of people to a care manager. The team, though, the caseload is roughly, we're looking at 100 members for the 3 care managers that we have, really, right? Kind of looking to manage. Now, the 100 comes from thinking about how many high level, medium, and low level folks you can manage, but that's the thinking, right? Kind of an overall structure. So if we move to the next slide, please. Again, so is to limit the movement, providing, the team approach is to able to stay with the care management team. And even though this is a team-based approach, we're still thinking, and again, this is something we're going to look to you guys to really tell us how best it works. We're still thinking that, because there's the flip side, right? There's the flip side of the individual saying, well, who's my care manager? There's like 3 of you. Like, who do I call, right, if I want to talk to? And so we're trying to kind of balance both of those worlds. The individuals, just like all of us, probably just want to know, like, who am I working with? But at the same time, the ability for others to help if need to. So we're still thinking that internally, you might still have designated care managers, as you work with these 20, you work with these people, you work with those, but the individuals should get introduced to the team, or at least be aware that there's a team, right? So if somebody else calls, They might not know that other individual as well, but hopefully they'll still be like, oh, you're part of the team, or you work with Anna, or you work with Lee, you know. And so at least there's that, I'm not just getting passed from one person to another, but it's really a team working with me. But on day to day, there's a designated person. And again, so that's our thinking, really looking to you to see, does that really work? How would that work? And, you know, do you then even internally at Monarch have to move people around constantly, even though the person might not really feel it? But so we're kind of trying to accomplish both things, right? Stop, kind of try to reduce or prevent the movement, but at the same time, offer that kind of individualize and that contact to that person. And that's the kind of the trick here, right? And looking to see how that gets accomplished. So again, as I mentioned, the CMA team, the care management agency team, it has, you know, a supervisor, director, you know, there'll be different levels of different organizations, 2 care managers and a peer, and that's what we have here. And really appreciate that. Some of the predominant tasks, you know, clearly it's, again, field and community based, but as I've mentioned before, you'll work with Monarch to determine what that really means. There will be telephonic engagement, you know, especially for low acuity, as I've mentioned before, and everything else we kind of talked about. The other things, and we'll get more into detail about documentation later, but of course, one of the main tasks is to conduct a care management assessment, and of course, initiate and put together a person-centered plan of care. And we'll talk a little bit more about it when we touch on documentation as well. So again, the roles and responsibilities, another way of saying it, boots on the ground, eyes and ears of the team. So as we mentioned, right, there's the whole issue about there's claims data, but people really don't know what's going on the ground. That's really your role, like one of the biggest roles, really that member engagement, working closely, engaging the individuals, providing those assessments, helping with the initial, the social determinants of health, the plan of care, as I mentioned, and everything else before. So if we can go to the next slide. So how does the workflow, how does this work? I think we kind of touched on this a little bit, right? So for the pilot, but if we take even before the pilot, right, we talked about the state designates or creates that eligibility criteria that says somebody qualifies for the tailored plan. They provide that to Alliance Health. Alliance Health then assigns members to you. So right now, the individuals you're going to be working with, at least the first 50 or so, the way they were assigned is Alliance Health looked at the data, and they wanted to make sure that the individuals you're working with, at least as an agency, Monarch is aware, knows these people, and I think there's potentially active somewhere in the Monarch system, meaning they're working with them. So the first 50 are not individual, should not be individuals, and at least the way we're working with, that as an agency, Monarch doesn't know who they are. In the future, that could happen and will happen most likely. But for now, at least you're starting with that group, and actually part of the pilot in probably the 3rd month, if we're able to get there, I mean, we might even assign some members that really are either were known to Monarch or have some limited contacts, but you might need to do a little bit more work in finding those people. But anyway, so Monarch does the assignment, they do their own algorithm. The way we're doing it now is, as I said, you know, really making sure that the agency knows this individual. Then Monarch, I think you guys already got that list, if I'm not mistaken, maybe even like a week or so ago.
Yes.
Right. And so then Monarch, I just, because I don't know what Monarch does, and that's totally fine. You would review the list and you would figure out what's your internal workflow. So definitely encourage you guys to talk if you haven't done so, and continue to figure out, okay, we got the list, what happens next? We're not going to dictate. We're happy if you have any questions to assist you or give you our thoughts, but it's really up to you to guys kind of have those internal processes. But then, of course, you would assign it to the care management team, who will start outreach and engagement, which will start on a week from now on Monday. And we'll talk a little bit about what that means, because it's not going to be to the extent we initially thought, but we want something to happen on that Monday, the 15th. And we'll talk a little bit about that. And then, of course, after you start the kind of that engagement, assuming the individual wants to continue with care management and opts in, you would start providing that care management services. So again, from the state to Alliance to Monarch, and from Monarch to you guys as a care management team. So that's kind of the overall piece of it. And then when you do get to the client, actually one of the things just before we even get to documentation, just to mention, no, you can be there. That's okay, Tara. Thank you. Is there is going to be a consent form that you would use, just like for any program. Individual signs a consent, right? And especially here, and that's going to be really part of your engagement process with the individual, where the individual will acknowledge, that they're willing to participate, especially since this is a pilot. We want to make sure people understand and that they're okay with this. And so part of the process is going to be working with those individuals and explaining to them what this is. And I know Alliance is working on some of that material to provide in regards to, so you can really use the material to engage the individual, and hopefully they're willing to sign the consent. We are okay. And again, I will defer this back to Monarch's policy, but we're on our end are okay to do verbal consent, meaning document that somebody gave you a verbal consent because you weren't able to see them. You did it over Zoom or by phone. Of course, a signature is always the best way to get a consent, but recognizing that, the situation we're all in, that might not always be possible. So that's really one of the documents that, kind of pre-starts any of this, right? Because if the person says, yeah, I know, but I don't want that, I don't like care management, I don't trust you, or whatever they might say to you, that's fine. You will document that and you will move on to the next person. One of our process is we're definitely giving Monarch more than 100 people, recognizing that there will be some folks that will decline. And so so that's kind of important to understand, but we'll be working with you to kind of see what is the rate of individuals willing to sign up for this, because that's another thing that's important to understand. And so when you get that consent, really your first process is going to be an assessment, right? Because what you want to do is to get through an assessment process, right? And so the assessment, so this is from the state, and we're going to ask and we're going to measure and try to measure how close this is possible, right? So the state is saying that the assessment must start within 30 days of member assignment. Now, since this is a pilot, again, this doesn't impact in regards to payments or, anything horrible. But we want to kind of think that through a little bit. One of the things we have to determine was the member assignment March 1st, which I think where officially Monarch got the name, or is the member assignment March 15th when you start that? Because it's a pilot, it's a little tricky, and we can figure those like little nuances in detail, but this is again just for our analysis purposes. But as a thought, as you kind of think about it, in the best case scenario, you would start at least at a minimum, not complete, but start the assessment within 30 days. That's what the state would like. And again, it could be very limited, very simple as by starting the company by telephone through Zoom or other means, and so forth. What the goal is to complete the assessment within 45 days of assignment. Right. So theoretically, if we use March 1st, and I'm just saying if, doesn't mean we will, if we use March 1st as a date, that means roughly by April 15th for those individuals who opted in, right? Because those who opt out and say, I don't want care management, you're not doing this assessment. But for those individuals who opt in and say, yes, I want care management, you would complete the assessments by middle of April or so. Okay. I think go ahead, Lee. In the meantime, I think we had a question or two. Go ahead.
Yeah, I was just going to ask a question about member assignment. Just kind of thinking through that, like you were saying, what date will we go with? Is there a scenario where we would use the date that they consented as the member assignment date?
Yeah, so one of the things, this is where we're trying to, back to the slide, where we're trying to mimic what we think would be in tailored plan environment, right? So Allison, jump in here, because I'm not sure that's going to be a way to do this.
I don't think so, because these timelines come from the state, and they don't say things like after the person consented. They talk about doing things within specific periods of time. Having said that, it will be interesting in the initial year's rollout to see how much the state relaxes, because the state actually does not believe that we will reach, we meaning the entire state, will reach and get consents from all members within their time period. They think maybe 30%. So, it'll be interesting to see how it adjusts.
Yeah, and also, this also will lead into, even, assuming that it's the true assignment date, meaning the day you get a list from Alliance Health, right? One way to potentially do this, but again, I think Alliance Health needs more information from the state to see if they'll be able to do this, is not assign everybody to Monarch on day one, right? So let's say at the end of the day, there's 500 clients that could be assigned to Monarch on July 1st of 2022, right? So one way is to give all 500 clients, and then of course you have to scramble and figure out how do you get to all 500 clients in this time frame, right? The other way, again, this will depend if the state will allow us to do it, and working with Monarch is to say, well, we'll assign 100 clients on July 1st, 100 clients on August 1st, and so forth and so on, to give a better, kind of a more realistic approach to this, right? And actually, that's how we're doing the pilot, right? For the next 3 months, you guys are going to get assignment, right? We're starting with, we totally have 300, but we're not giving you all 300, and that's part of the testing here as well. And I know there was a question, and Kate, thank you for answering it through chat as well, in regards to, will there be tools and so forth. So we'll go through the measures at the end, and thank you for that question in regards to, how we're measuring this. And also we'll look at you guys to tell us what else we should be looking at that we might be missing in regards to see if it's successful or not. But we'll go through some of those. I don't know if we'll have a survey potentially. We might, we did potentially have a member satisfaction survey. I'm pretty sure Monarch, you guys probably have a patient or a client satisfaction survey in your agency. So we can talk that in the future as well. But there's definitely many other measures we want to make sure that we capture to see if it's successful or not. So the next slide, please. And so the reassessment, and it, there's a lot here, so I'm not going to go through all the little details here, but clearly there's going to be a point in time where reassessment needs to get done. So according to the state, you will need to do it at least annually at a minimum. We also, there could be significant changes, right? Meaning like the acuity maybe will change, or something happens, or a member actually might ask, maybe, I don't know if they'll come and say, I need a new assessment per se. I mean, this is against state, saying this, but there might be a way that maybe a member is kind of indicating that a new assessment is needed. So if we can go to the next slide. So there's a lot of information that the state provides on when they think a reassessment is needed. I think some of it totally makes sense, right? Of course, if somebody goes into the hospital, has a, 2 or more emergency room visits, and, or, some significant social determinants of health, like losing housing. And when we say reassessment, and this is something we're going to need to think through with you guys, is what does that really mean? Does that mean you have to do a full new assessment, or are you just targeting those areas that maybe are impacted, right? Or maybe some of the particular parts of that assessment. But we definitely want to make sure that part of this process, that there is an opportunity to for you guys to do reassessments, and when. And also we want to make sure that we start thinking about how does technology help in future, right, to help with these triggers, so we're also tracking it appropriately. So if we know somebody went to the hospital, can technology in the future tell you, hey, don't forget to do a reassessment, right? And so forth. Some of it might be harder to use technology for, some might be a little easier, but those are all the things. And then we're going to be tracking, right? You guys are going to find out some of these triggers, and we're going to rely on you to see how close we can get to reassessments. So next slide, please. And the reassessment times kind of lines here is that the state is looking for reassessment to be done within 30 days. And this is from the point of the event, right? When something happens. So clearly there's no more assignment here. This is more about somebody went to the hospital, they come out of the hospital, you have 30 days from that point on to do a reassessment, right? Or all the other triggers that might be there. So I think from that perspective, it's a reasonable timeline. But again, we have to look at what is that reassessment looks like. I'm hoping that we can make it more of a focus. And again, using technology, you know, you're not starting from scratch because you already completed the assessment and most of the information is captured there, right? All right, next slide. So then after you complete the assessment, you know, the next logical step would be a care plan, right? You start working on a care plan that, you know, if you think about that golden thread, right? You kind of have the assessment that informs the care plan, you know, which eventually informs the kind of the activities and things that you do. So the care plan needs to be completed 30 days of the completion of the comprehensive assessment, right? So let's again just play out some of the timelines. You got the assignment on March 1st. I'm just going to keep it simple. You completed the assessment on April 1st. You would need to complete the care plan by May 1st. All right, so that would be kind of the rough timeline in that example. And understanding that, you know, you'll have kind of the best effort, right? Because things happen. That maybe something is going on with the individual you're working, you can't get to them, they are not responsive, maybe the 30 days slips and you need to go beyond that. And so as long as I think the documentation is always plays that key role, letting you know, letting us know, letting Monarch know that, you know, what might be happening, especially if the timelines are slipping. And again, this is a pilot, we want to see this, and any of that documentation would be helpful, especially through the notes, right? As you use your notes to document interactions, your outreaches, your contacts, and so forth, to also indicate that, you know, some things are not working out because X, Y, and Z, whatever the situation might be. Because what we want to do is analyze and say, well, you know, 20% of the time, this 30-day timeline doesn't work. But then we want to say why, right? Is it because, you know, the individual became disengaged or hard to contact? Is it because of other circumstances? And we want to better understand because we want to see, are there ways we can improve that timeline as needed? So as with an assessment, we also have, as the next slide, we also have an update that needs to get to the care plan, right? And the bottom line is when you think about updates to the care plan here, you really think about it, it comes, you know, kind of hand in hand with an assessment. So again, it's minimum every 12 months. What I would say is like if you're doing an annual reassessment, you would follow that an annual care plan. Of course, when anytime you do a new assessment or reassessment, you need to think about, does that change the plan? Does that change what you're working on? Does that change what needs to get done? A lot of times with those major triggers, it usually does mean that. But there could be instances that no, maybe the plan is still good. Maybe the intensity just changes. Maybe instead of, you know, you're seeing them once a month, maybe you need to see them twice or 3 times at least for a short period of time just to make things work out well. Here, it could be at the member's request, right? They might say, look, I know we're working on these 2 things. I really want to work on these 3 things. So maybe there was no new assessment really done. Maybe there was no triggering event or of any sorts. But the member actually says, hey, you know, I really want to change what we're working on. And so kind of thinking through about that as well. And again, it needs to be completed within 30 days of any reassessment. Again, at least at a minimum, indicating that it might be okay to move forward as is with no changes or with changes. But one way or another, it would need to be indicated that. Okay, next. So here we kind of talked a little bit about, and these are numbers and kind of the state thinking about how often and how much you should be touching each individual. And so the slides before were really built from this a little bit. So this should be hopefully in line with the acuity level. So this is like you do your assessment, you do your plan. You're also going to have, of course, your notes. I would also, especially as a team, and I'll leave this to Monarch's policy, and this is something definitely as an agency policy you should follow. But as a good rule of thumb on notes, right? Because we don't have slides here on notes, because again we kind of leaving this to Monarch to work this with you. But just to say, put 2 cents into it. So notes are always great to do in a collaborative fashion, right? When possible, and when both the individual and you are able to do it. And so basically what that means, you're actually completing your note there in a session, right? And so the easiest example for somebody like me who's not a clinician, right, is to kind of say at the end of the session, there's many different ways to do this, right? At the end of the contact, you kind of say, okay, we just spoke for 30 minutes or half an hour or an hour, whatever it might be. Let me make sure I understand. Let me, write this kind of our contact together, summarize it, review it with you. I've seen people actually show the notes. I've seen people in the office turn their computer around and say, here's what I'm typing. Does this reflect our conversation? I've seen people do many different ways. That's really the best practice, right? Is to do that kind of collaborative documentation and also show the person that what you're documenting is really what was discussed and they agree with you. So there's many positives to that, right? One is that literally after the session, you're really done, right? So that whole kind of, I got to go home and do notes is not hanging over your head, right? I say Lee is going to
Yes,
jump in because,
absolutely. Yeah,
right?
Monarch, we do a lot of the collaborative documentation.
Great.
I came from the outpatient world, so we were doing collaborative documentation in our clinics. And so I imagine as long as technology wise, we have the functionality to do that out in the field, then that's exactly where we're going to want to go with this, because our care managers and our peer support specialists is going to be really important to maximize that time with the individual and not have to worry about doing those notes when you get home.
Yep. Yep. And we also know from research the staff satisfaction, the level of stress and anxiety is much improved because again, that whole burden of doing the notes and finishing your work at the end of the day goes away really. The other thing to remember, in addition to all of this, especially when you work as a team, if the notes are not completed timely, right, and really anything more than 24 hours is not timely, and some people would even argue 24 hours might be not timely, it also creates a potential problem, right? So let's say you're about to go on vacation, or you're not feeling well, so you're really need to take a day off or whatever it might be, and the person calls the next day and says, hey, I just saw Lee yesterday, but I got to talk to somebody, right? So any of your team members who pick up that chart, and I still say pick up that chart, even though it's a computer, and looks at it, there's no documentation. So you as an individual really don't know what Lee talked to you about and what happened. And so now you're relying, not that it's a horrible thing, but now you're relying on a member to say, hey, can you tell me what happened? And you probably should do that anyway, but at least you have now perspective of your team member, right? And especially if it's a crisis, especially, so that's within your team. But imagine if, when you establish those relationships with hospitals or other providers, if they're calling from the emergency room and says, hey, we have one of your clients here, can you tell us a little bit information on what's going on? and the last person didn't document, and so nobody has really understanding of what happened in the last visit. It also creates those, risk factors, and really doesn't provide great quality of care. So there's really many aspects to it. So I think it's important to try to make sure that that note is especially documented. And through those notes and those contacts leads to us being able to also track how many of those visits happen, right? So again, for high acuity, we're expecting, roughly 4 contacts per month. At a minimum, it includes 1 in-person contact with a member. For moderate acuity, we're looking at, or the state, I should say, these are state requirements. They're looking at 3 per month, at least 1 contact with a member. A comprehensive assessment, it could be part of that. For low acuity, they're looking for 2 care manager to member contacts per month and at least 2 in-person contacts per year, approximately 6 months apart. So I think, we'll see how this goes, but again, not to rehash the conversation we had, but really going to be looking during the pilot to think through with you, where these things land, and for you not to, strictly follow these rules, but really follow what you guys think is needed for the individual. And Lee, you said this, and I'm going to say it, and especially Wednesday, we'll talk more about that whole person-centered, whole person approach, right? We can't emphasize enough of that, because even though we might think you need 4, you might say I don't need 4, or we think you need only 2 a month, and I say no, you got to be here every week because I need that, right? And kind of working through some of that as well, and making sure that the member's voice is heard as well. So I think that's crucial. So next slide, please. So here's some of the measures that I've talked a little bit about. There was a question about how we're going to measure this. So there's the kind of these HEDIS, other types of, I would say, clinical measures or medical measures. And then next slide, when we get to it, we'll also talk about some of the measures we're looking to start with for the project, right, for this pilot. So some of the measures that Alliance Health will be looking at, and we'll be, and then we'll got to figure out where in IT it is and how do we get that data and so forth. But so you guys know, so some of the preventive measures is just flu vaccines, right? And medical assistance with smoking and tobacco use cessation, right? So clearly we're not expecting you guys to do flu vaccines or provide that medical assistance with smoking and tobacco use cessation, but we're gonna, as part of the care manager's job is to see how do we engage and encourage individuals to get those vaccines, and also, for those who are smoking, how do we encourage them to at least get some of that assistance, right? And also work with some of the providers who provide that assistance to see are they working with the individuals and implementing that. In regards to care for chronic condition, for this pilot, we'll focus on the controlling high blood pressure. Again, not every individual would be part of this, because if the individual doesn't have high blood pressure, but for those who do, and that could be anywhere from their primary care physician's office to maybe they have a cardiologist, and so I think, that's kind of important to recognize, and again, being mindful of individuals who have different chronic conditions. Some of the mental health measures, probably not surprising, will be the mental health 730-day follow-up. And this is post-hospitalization, really, we're talking about making sure that individuals, to the best of your ability, connects with a licensed or appropriate level of care post-hospitalization 7 days, and then, again, 30 days later, or at least one of those, but hopefully for both. Diabetes screening for people with schizophrenia and bipolar disorders, who especially are using the antipsychotic medication, because we know with some of the antipsychotic medication, it could increase the risk of diabetes and so forth. And of course, the adherence to antipsychotic medication. So the first 2 bullets, the follow-up and the diabetes, is clearly you guys, again, using, working with individuals, connecting them making sure they're, the providers are getting that screening and people are touching base, and as well with adherence to antipsychotic medication. But I think with adherence, we'll also see you playing a little bit more of an active role, right? At least when you engage and talk to the members, is to talk to them about, are they taking their medication? Are they refilling their medication? So it's not just about go see your psychiatrist or social worker or whoever it might be to, for them to check if you're adhering to antipsychotic. They should be doing that as well. But, part of your job is also to work with individuals and talking to them about their medication. And if they're not either refilling or taking, trying to understand and then also conveying that to the treatment team to see how they could assist in improving that adherence to the medication as well. And continuing with some of the measures, so that was mental health and substance abuse, very similar, the follow-up as well, but just in this case, it's substance use, right? So if somebody is going to a detox and so forth, and of course, initiate an engagement of alcohol or other drug dependency treatment, again, for individuals who would need that. So that's the measure on the substance abuse side. Some of the avoidable utilization is emergency department use. So we're going to be measuring how often people go and use the emergency room, emergency department, and what are some of the interventions could be put in place to try to reduce that for especially individuals who are using emergency department a lot. And sometimes it could be clearly clinical, situational, and sometimes it's social determinants of health. So I know I'll use more of a example that's probably would work both in North Carolina as it does in New York. So I know I've worked on a project, for example, where in care management, right, where during the summer, sometimes in the peak of summer, like August, right, you see some of the spikes in the emergency room visits. In New York, you also see that in December and January, but for the different weather reason. But when you see extreme weathers, right, either too hot or too cold, sometimes there's a peak in emergency room visits. And that's, and when you unpackage everything, sometimes it's just individuals, especially for homeless individuals, right? It's a way to get into an air-conditioned room, get some food, or get into a place where it's warm because it's the middle of winter, get some food, and kind of relax for a little bit. And so it's more of a respite rather than a true emergency. And some individuals have learned what they need to say, right, to get into it. And not to say that they don't need the emergency room, don't need that service, but trying to understand. And sometimes it is, serious and needs to be addressed. And, maybe there were thoughts of suicide or other things that are going on, but kind of understanding that. So that's one of the emergency department utilization. There's also important member experience, right? Kind of, and I think that was a question before we talked about a satisfaction survey. So looking to do that. And as we talk about the pilot, and these are just the beginning thoughts, but there'll be many more other measures, is even trying to understand what was the average time for you to get in contact with the person, right? And when we say time, we're not talking about hours, right? We're talking about days. So if you start making those phone calls or whatever it might be on Monday, the 15th, were you able to just pick up the phone and the person answered and you were like, boom, you got into contact with them? Or did it require you 3 calls? Did it require you to get in a car and go to their house? Like what was that timeline? And kind of understanding that number of integrated assessments completed. I talked a little bit about within 30 days, like how well were those assessments. And I said 30 days, even though technically you have 45, but we want to kind of see within 30 days, because also, if I'm not mistaken, Allison, this was to your point, the state has 2 different standards for year 1 go live versus after year 1. And I think year 1, they're trying to give a little bit more time understanding some of the things. I don't think it's a lot more, but at least there's some understanding, it seems like, or willingness. So we're really measuring more like this year 2 already pilot. So I don't know, Elsa, right?
So I think what you wrote down here is a little bit more restrictive than year 1, and also the acuity measures vary somewhat the time varies depending on what acuity level somebody's in.
Yep.
And I don't want to quote numbers because I'd have to read them.
Yep.
And going back to something Boris said earlier, you know, when you read what the state says, it sounds like we, at the beginning of year one, that we have to give everybody all the information all together. But one of our consultants with the state has said, you know, different people are viewing that differently. And I suspect that all of these things may be things that we can discuss with the state, as Sean pointed out earlier.
Yeah, definitely. Yeah, no, I think you're right. And I'm not going to quote those numbers either, but I think it really goes into like this, I would call it almost a rabbit hole, like how fast you have to complete an assessment for whom, year one versus year two, if you're high acuity, low acuity, all that stuff is in there. And definitely, you know, and I kind of understand that, right? Because if you're high acuity, the state wants you to get out there and get their assessments as quickly as possible, versus if you're low acuity, they suspect that you have a little bit more time. You know, they're less concerned about some of the risk factors. But that's why we're here. This is probably might be the most restrictive in regards to the measure. I think it's year two, high acuity, or something like that. But again, this is just a measure. It doesn't mean that it's a bad pilot or good pilot. And we can definitely, if we need to, get down into that rabbit hole and analyze it by acuity levels, and how well those assessments, but just for simplicity of factor, just kind of trying to keep it at one level or one time frame.
And Boris,
Yes.
this is Donna. I'd like to
Yeah.
interject that
Yeah,
on
please.
the previous side, when we were talking about the measures, that Monarch is already receiving monthly scorecards for some of these measures. There's a medication adherence and a diabetes screening measure, and the 7-day first follow-up for substance abuse and mental health. So we'll just be adding to these measures over time and working with them on their understandings of them.
Oh, great.
So.
Oh, that's great. That is actually great. They're like, you know, halfway there. So that's actually good.
I wouldn't call it halfway, but yeah, we're there.
Yeah. I mean, from my experience, the fact that you're already sharing some of these measures, you're halfway there. Because usually in these types of pilots, you're like, all right, so how are you going to share that, and who's going to give what to whom and when? And so no, that's great. No, I know there's much more to go.
We just have to figure out how we're going to differentiate overall Monarch data from the CMA pilot. But other than that, and then we'll expand on these. And like the measures we're already sharing, we'll provide them like one-pagers for understanding what the measure means and how do you work with the measure. I usually give success strategies to work in, so you're starting hitting the ground running with the understanding of the measure.
Yeah. Excellent. All right, and so the last measure, but again, we'll have many more, is looking at the number of contacts per month, right? Again, we talked about are they hitting the 4, the 3, and so forth, as it relates to this. All right, so next slide. All right, so let's pause here and see if there's any questions or thoughts or comments.
So, all right, let's see. Is everybody kind of, I'm just guessing that most people are back. So let's get going.
Yeah, so.
All right, guys. So one of the things that we're going to talk
I'm here.
I'm sorry.
Okay, just so you guys know, I'm still here.
All right, I'm
Okay.
counting on it, Rosa.
Sorry, I interrupted.
No, you're good.
Okay.
Good to know you're here. All righty, so we're gonna, it's gonna sound a little bit redundant because I'm gonna talk about eligibility, but I'm also gonna talk about it in relationship to Alliance, not just the standard plans and tailored plans. So, and not just the pilot, I should say. So it's a little bit broader, but anyway, so the standard plans, we've talked about them. Folks are going to get Medicaid through what were private companies, and they will get your basic physical health and behavioral health needs met there. And as you see, some of them also provide some other value added kinds of things like transportation. Most of them will be providing transportation, helping you quit smoking, other kinds of wellness incentives like gym memberships and those kinds of things. And then of course, the behavioral health IDD tailored plans are what, we are planning to provide in 2022. And it's for a very much smaller population. And to give you an idea, right now, currently with Medicaid, we cover about close to about 270,000 people. And when we go to tailored plan, we project around 31,000 was the last number I heard. So that gives you an idea. These are the most complex people that we will be managing. Folks with IDD, traumatic brain injuries, as Boris was talking about earlier, and among many others. Most of your serious mental health issues, and folks who are receiving other services that are not offered by standard plans, and we'll go through that. You can go to the next slide.
And Kate, and again, a person could only be in one or the other, right? Just to want to
Correct.
emphasize
Yes.
that. Yeah.
Thank you. All right, so in order to be eligible for Alliance, you'd have to have Medicaid or Health Choice. And Health Choice is a child category of Medicaid that you probably wouldn't run across in the pilot. With Cumberland, Durham, Johnston, or Wake, you guys will be focusing on Wake County, obviously. Tailored plan members, as we talked about earlier, are going to be assigned by the state. And in general, it's your IDD diagnosed individuals, folks on the innovations wait list or enrolled in innovations, and TBI waiver recipients. Transitions to community living population. And these are folks who, through a lawsuit in a Supreme Court decision called the Olmstead Act in 1999, that really made it illegal to separate and segregate folks with mental illness from others, and in institutions like hospitals and adult care homes and those kinds of things. So we have a pretty big program to help these individuals move into housing and be independent in the community. So in order to be eligible, you'd have to have services currently only offered by behavioral health IDD tailored plan. And by design, when we get to tailored plan, we would be covering folks that are uninsured with some benefits, and that's something that won't be offered by the standard plans. And certainly those innovations and waiver services are not offered by standard plans. So there's a host of services that we'll talk about in a little more detail in a little bit. Children with complex needs, and these are kids who are have co-occurring IDD and mental health issues, serious emotional disturbance. And then there's a reference to the link that has a complete list of populations and eligibility, in case you're interested and you want to do some light reading, right, over the week. All right, you can go to the next slide. Thanks. So this is a list of services, and there's links behind this that are available through Alliance, and we'll talk about those and I'll show you the website so you can see how to navigate and find some of these services. But in general, crisis services, and what we're talking about when we talk about crisis services, is alternatives to the emergency room. And what you already saw with the slides earlier, that's one of the things that we want to avoid is unnecessary trips to the emergency room. So crisis services are things like our mobile crisis management in Wake County. That's provided by Therapeutic Alternatives. It's also behavioral health urgent care, which is provided by Monarch in Wake County. Also things like the facility-based crisis programs, which is like Wakebrook in Wake County. Also crisis and assessment centers. And again, Wakebrook has a crisis and assessment center on the front end. So say somebody was in crisis at 11 o'clock at night, behavioral health urgent care isn't open 11 o'clock at night, they could go to crisis and assessment. So, and mental health recovery services really refers to some of the, what we call, you will hear referenced as enhanced services, like assertive community treatment teams, community support teams, you will psychosocial rehabilitation, and I believe you guys have one of those in Wake County as well. So you will hear those referred to as enhanced services, and those will be services only offered through tailored plans. Substance abuse and substance use disorder services. Again, there's a wide range of those covered by both standard and tailored plans. And so there's substance abuse intensive outpatient programs, substance abuse comprehensive treatment programs, and then also your opioid office-based treatment programs, medication-assisted treatment. Those are actually offered through both plans. Folks with intellectual and developmental disabilities, folks on the very clear ones, folks on the innovations waiver, definitely go into the IDD tailored plan. If you have an IDD diagnosis, you're also going to be going into the tailored plan. You may be on the wait list for innovations services. And for those of you who may not know what that is, Innovations is a Medicaid waiver program covering folks with IDD, but there's only a certain number of slots given to the tailored plans or the LME MCOs annually. And so unfortunately, those slots are not plentiful enough to serve everyone that has that need. And so we have what's called the Registry of Unmet Needs, and we keep that, and that is where we can see where people are on it's essentially a wait list, but in waiting for one of those slots. And if you have an innovation slot, you're eligible for an array of community services, such as alternative family living programs, otherwise known as AFL, residential, community guide, and others. And those services are not available in if you're not on the waiver, or definitely not in the standard plans. Traumatic brain injury. Alliance actually has the first TBI waiver program in the state. And as the tailored plans start rolling out statewide, that actually will incrementally go to additional areas. So to be eligible for traumatic brain injury, we'll talk about that a little bit, and it's very specific criteria that we'll talk about in a bit. And as Boris referenced, you may come across somebody who has a traumatic brain injury and say substance use disorder at the same time, and they may not qualify for the waiver given some of the parameters. And so you may need to seek some services around traumatic brain injuries for an individual, but they're not eligible for those waiver services. And we'll talk about that in a second. And then transitions to community living. And that's what the population I talked about just a minute ago, and those individuals who are coming out of institutions, going into the community, and being as independent as they possibly can. We really want people to go into their own homes in the community with supports whenever, and without supports whenever possible. All right, next slide. So this is in our website, and I'll hit this, but there's eligibility and enrollment criteria very specifically on the website. And one of my goals today is to take you through that so you know how to find information that's going to be really helpful to you guys. And then clinical practice guidelines. This is a document that's updated annually. And I think your medical director actually is part of the group that updates it. We have a group that Damali helps facilitate called the Provider Quality Committee. And what are you doing, Ellison? You're yelling. The PQC actually does annually update these clinical guidelines, and that's a group of clinicians. You basically your chief clinical officers or your chief medical officers of several organizations, and they work together to update this. It's really your gold standard treatments. And so when you go through that, it kind of gives you the guide for clinically what we'd like to see folks getting for specific disorders. All right, next slide. All right, so as I went through the services earlier, I gave you some detail through transitions to community living. I mean, really what you're going to see are services for specialty populations. And that's what I would say are your TBI services, your transitions to community living services, some of your waiver programs. And also then we tend to sometimes develop services for smaller subsets of populations, in particular co-occurring disorders, et cetera. So those services are on the website. The other thing you'll find is how decisions are appealed. You guys you'll have your service providers that you're working with who, on behalf of an individual, have requested an authorization. And say the authorization was denied, then individuals always have the right to appeal, and this walks you through how to appeal. And again, those are just links we'll go over in a second. So next page. All right. And state funded services are those for folks who are uninsured, or it's a benefit that's paid for by state funds that's not available through Medicaid. So this area is going to take us to understanding the eligibility and benefits, the utilization management guidelines. We have those benefit plans outlined for both state funded services and Medicaid funded services. And you'll be able to see exactly what's offered and what those entrance criteria are for each service. So you can help your service providers who, if you have a brand new provider who's never navigated that, you guys might be advising them on where to go. All right, next slide, please. And again, we're going to get you to all the eligibility documents, and it's separated by, it's separated in utilization by IDD and by mental health SUD. All right, and what's the next slide, please? All right, so let's hold. I'm going to go ahead and share my screen, and then we'll go back to this slide. All right. So you guys should be able to see, I'm in the Alliance Health website, but I'm actually at the section right now where it talks about the approved clinical guidelines. And I gave you this link. So if you go to, let me go back here. What? I love this. When we update anything, it is absolutely awful to get to. All right, so if you see right here, we're under approved clinical guidelines, and now I can't navigate it. So that's weird. But anyway, here we go. Now I go around. Found it. So that's what it'll look like. And you can see medications. You can see the reviews and evidence summary for treating bipolar. And it gives you all sorts of references here, dementia, eating disorders, etc. And this has a lot of information for clinicians. You guys may not use that as much, or you may, but it gives you lots of behavioral health information and very good supports in terms of references. All right. So let's go back up here. When you go to providers and you go to working with Alliance, you see this list that says authorization and claims and information. So that's where we are. We're going to do some information. And there you Go down. There. So here's your eligibility and enrollment. And this gives you right here all the target populations that are under the state plan, the service array, any benefit plan diagnoses, service array. This is all around state documents, state funding, and it takes you there. So I want you to be able to navigate that because it will give you like this. Let's look at. Have any of you guys worked with target pops before and the priority populations? I bet some of you probably have. This is here's your adult mental health priority populations. Shows you who are priorities for services in terms of, so the state at risk of harming themselves or others, obviously. And again, going down, you've got that with child, risk of homelessness, TBI, very similar between adult and child. Then you go to substance use disorders, pregnant women who inject drugs, alcohol and other drug use, etc. Opioid use, DSS involved. And then you go IDD priority populations in your adult and child. And those are your long-term populations. And then this gives you the benefit plan list. This is all for state funded services. And you may run across state funded, even though uninsured may not be receiving care management, there are times when you could run across somebody who might have a state funded service just because it's not offered by Medicaid. So they'd be Medicaid eligible, but they could get a state funded service, if that makes sense. All righty, let's go back here. All right, so I'm going to go back to the resources. Let's go to IDD resources. And again, you're getting this for providers and working with Alliance. So this gives you the IDD resources for us under Medicaid. And then innovation services under Medicaid, it tells you exactly what people need to be eligible and to be on the wait list, the registry of unmet needs. This also gives you some other services and supports individuals may be eligible for, etc. So it really gives you, it also links you to the clinical coverage policies that are directly by Medicaid. So this gives you a list of all of the definitions. And this is what we call the benefit plan. So this is your Alliance benefit plan. So when you're looking at services that people need in terms of behavioral health, and again, you won't see physical health here yet because we're not managing it until 2022. So when you look for services, you can read what services are available. And for example, you can see here, this is the clinical assessment. It takes you to the information about the clinical coverage policy. And that's true for every service. There's either a definition or there's a clinical coverage policy. All right, so that's under IDD Let's go to MHSUD because most of your people are going to be MHSUD, obviously, is what we had designed. So let's go down here, working with Alliance, you go to your mental health, resources. And here you'll see what it looks like. There's assertive community treatment team. We have some alternative definitions, which you'll see in here. Here's your behavioral health urgent care, community support team. And again, you click into one of these and it gives you all the information about when's it covered, what the entrance criteria, continuing care criteria, and the exit criteria are. Okay. Questions on that? This is going to be an area where you're going to spend a lot of time, more of your time looking for service eligibility would be around the benefit plan and what services are there. And let me go back to this for a second, just to show you one other thing. So this is Medicaid benefit plan. You scroll down and we have a lot of, this covers children and adults. So that you'll see lots of services here. All right. So that's all Medicaid. Go back up here. And then you can see non-Medicaid. We'll get to that. Here you go. This gives you everything. That's your Medicaid. Gives you lots of information. Here's your non-Medicaid benefit plan. And then this gives you other things that you won't need as part of this pilot. You might need later on. Just some specific services that have specific requirements that you have to meet in order to be in those that are different than your typical coverage policy. All right, blowing through a lot here in a short amount of time, but I want to pause. And I know I saw Anna say that she had worked for Alliance before in the call center. So this is probably nauseatingly familiar for you. Although the website may have changed since then. Questions, guys, on that? Okay. All right. So let me stop sharing real quick. Find where to stop share. There we go. I'm in a very different. Now I can't even find the bar. Oh, there we go. There we go. Thank you. All right. So as part of, and of course, the information that I just went over, you would use around with service providers and in developing a care plan with your members, and just figuring out what is needed. But there's more than that. And these are just your basic services. So there may be other stakeholders or interact with your members, or and there's community groups such as NAMI, the Alliance for the Mentally Ill. There's also, we have consumer family advisory councils that meet, that could be interacting with members and could be advocates for members or be part of a team in terms of their natural supports. So they would be stakeholders that might be interacting with your folks. And I've talked a little bit about other programs that serve distinct populations. One of the things that I talked about earlier too is like the distinct population, the TBI waiver. For example, we used that earlier, but you have to have had the injury onset age 22 or later, and so not before. And lots of kids have, traumatic brain injury. So it eliminates a good part of that population. So again, there's just a lot of criteria that are that's on the website related to those specific populations. That would be nuances that you might need to know. Social factors, and of course, these, you guys who have been working in the field have seen this impact people's health. And now there's wide recognition that without some of these things, people really cannot focus on their overall wellness. And substandard housing, not having housing, being homeless, having food insecurity, and of course, lack of access to communication, transportation. The pandemic has really brought out that lack of communication. It's really, really difficult for people to communicate when they don't have access to virtual platforms or internet. So those are things that as care managers and as part of your team, you guys together, your team will be looking at ways to connect those resources with your individuals. Using NC Care 360 and seeing the other kinds of agencies out there who would support those kinds of things like substandard or food insecurity. We do have some housing folks that would be available to you for support. And I've shared a list of contact information with Lee. So she has that in her mailbox if you haven't seen it today. And that will give you a couple of our staff who help with housing. One is filling out our housing applications. And the other, I can't remember which area it was, but I think it was really finding individual leasing facility, leased apartments and those kinds of things. So again, there's a couple of resources that we have who know that we'll be supporting some questions from you guys. And also there is periodically ILI training, which is actually helping people find housing resources and getting access to housing. There's applications that are able to be filled out, and that training will help you access all that information online. So keep your eyes tuned for that. All right, and then the other thing I just want to mention is the use of video remote interpreting and being familiar with some of the pros and cons and the operational issues around that. So video interpreting can be used very quickly, and it can be arranged very faster than some types of interpretation. And typically, you have a lot of, you have very well-trained and certified individuals and professionals providing it. But the con is you are on internet-based, and people have to have enough connectivity and bandwidth to be able to use it. And it's also kind of difficult for managing the environment. Sometimes seeing the environment is really important in that context, and you don't get that necessarily when you're just using VRI. And so with people with low vision, it has limited, it has some limitations there. So just be aware of that. And I think we'll just pause for a second and.
Yeah, I think next slide is just questions.
Yeah.
And discussions. I know we only have a couple of, few minutes left. So thank you, Kate, for that. So just wanted to really open up and see if there's any, there's a lot of information here today, and more to come. I just want to see if there's any questions before we wrap up.
Yes, I just have a question about, so we're going to be using NC Care 360, and so we're going to be getting trained on that. But as we gear up getting trained on NC Care 360, and as NC Care 360 continues to expand its database, is Alliance using any internal database that you already have as far as community level resources, not services through Alliance, but those community level social determinants of health resources?
As far as I'm aware, and Allison, Damali, Donna, jump in. As far as I'm aware, we don't have a standard database that we use other than NC Care. We're using that as well, the platform. I think there are individual resources. Certainly, our housing is a wealth of information all on its own, but I don't think we have any other database that these guys are using. Am I correct in that? I'm hearing nothing. So they correct me really fast if I'm wrong.
Are you trying to find out if we know about resources that aren't in NC Cares 360?
So just kind of thinking through this, I know the NC Care 360 is still growing. And so if there are resources in the Wake County area that maybe are not present in NCCare 360, or if there's while the team is getting trained to utilize NCCare 360, is there some other resource guide?
There
Off
is.
the top
Wake County put out a resource guide called something like Wake
It's
Alliance or
Wake
something like that.
Network of Care. And I'll make sure and send you the link. I've got it. I'll send you the link because it's a great resource for about any listing in Wake County you would ever need. So I'll definitely send that to you.
Okay,
But they are county specific. So there's a Wake and a Durham, but that doesn't mean.
But for example, there's not one in Cumberland.
Right.
And so that gets tricky. I don't believe there's one in Johnston either, but they actually, those two counties got a grant to help them get the listing on the net. So, but fortunately for you, Wake is probably a very, very good one. And I would say, when it revolves around access to care at this point, Anna, as your provider network development specialist, if there's a specific question, if you've identified a member needs X, but you can't figure out where it is, I think that's okay to ask Anna if she knows, if she can find out if there's a resource that we use. But I think, there's no easy answer. There's no one place. That's the problem.
Right. And NCCare 360 one day in the future, hopefully will be that place, but it's just going to take a while for it to grow.
Yeah, it's just not there yet. It's going to be great when it's 100%, but that rollout is still in process. So.
Yep.
I would imagine that a lot of the access and information specialists and clinicians probably make referrals on a regular basis to a lot of county-based local resources for things like food banks, domestic violence shelters, clothing, that type of thing. So, maybe that's, I know when I was there was a OneNote that we would kind of capture all of that on. And when I left in 2014, we were in the process of working with Provider Network to see if we could get some assistance with keeping that updated. So just curious if that's something, in terms of resource sharing that might be accessible.
Yeah, honestly, you bring up a really good point. I'd say when you get stuck, it's not, they know more than most anybody in the organization, as you know, from your experience. I mean, they're kind of the hub. So use that access line. It's 24/7. Our staff are not. Let's face it, they're not. They leave at the end of a regular workday, so they're done at 5 on Friday, and they don't come back until Monday. But access clinicians are there and can, they probably refer to a lot of those resources. You are right. So use that.
I'm not aware though, Anna, that there was an ongoing between Provider Network or Community Health and Access, us creating a list like you're sort of referring to. I think what's come on along the time is both the Duke and not Duke, Durham and Wake, that was a county level responsibility. And with NCCare's 360, I don't think we decided to move forward, but I'm not diminishing that access specialists know tons about all kinds of things in the community.
Absolutely. And again, this was in 2014, so I'm sure a lot has changed since then. So.
All right. Well, we're over our time, but thank you. I appreciate the discussion. And hopefully it was helpful today. We'll pick this up. The next training is on Wednesday. So we'll have much more time to discuss and other areas to cover. And for some of us, we'll talk in like an hour and a half or so again. But really appreciate everybody joining in for the discussion and your comments. So thank you, and talk soon.